In this lesson, we are going to focus on why someone might be interested in filling out a PAD, steps towards advocacy including provider education, patient education and support, and implementation. Research has shown that using a PAD reduces the number of subsequent hospitalizations that someone has. Practically, this means fewer days, weeks, and months of distress. So, let's investigate why that's the case. First and foremost, the role of a PAD, like any advanced directive, is to protect the autonomy of the individual who uses it. The Georgia State PAD bill even begins with the quote that PADs were enacted in recognition of the fundamental right of an individual to have power over decisions relating to his or her mental health care as a matter of public policy. As science and the patient self-determinism movement have progressed, we've grown in our understanding that just as those with physical ailments have a right to a say over their bodily autonomy, so too must we parody that in the mental health treatment system. If you look back over the history of the mental health care system, we have seen how some attempts at helping individuals were once praised, like the lobotomy winning the Nobel Prize in Medicine, are now seen as acts of abuse. Because of these relatively recent injustices, people understandably can have a lot of anxiety about how their rights will be respected within the help-seeking system. PADs serve an incredibly important role of communicating an individual's lived experience with a diagnosis. Providers on crisis intervention teams likely have little to no previous experience with the patient they are seeing. This means they have very limited knowledge about what treatments the person has tried and what's been successful in the past, meaning they have to reinvent the wheel each time. PADs allow patients to communicate this information to expedite the patient treatment matching process. By using a PAD, an individual can communicate if they know that a treatment will be intolerable due to adverse side effects like severe akathisia, critically low blood pressure, cardiac issues, and treatment-emergent suicidality and/or mania. PADs have been shown to support empowerment, minimize experience coercion, and improve coping strategies, which all lead to improved experiences with the mental health treatment system. But why is it that research has shown that using a PAD reduces the number of subsequent hospitalizations that someone has? To understand this, let's zoom out and consider what acute care does. The main goal of acute psychiatric care is rapid stabilization. Usually, this means putting someone on more medications at higher dosages than they would be expected to take long-term as maintenance treatments. By doing this, you get someone to a point where they can step down to a lower level of care as quickly as possible. It's then in these outpatient settings where individuals will transition to maintenance medications and dosages. However, as we all know, medication switches are one of the biggest causes of instability, which means that people can frequently cycle in and out of acute care while trying to get established on effective maintenance treatment regimens. By sharing an individual's treatment history and preferences, PADs help individuals be put on a medication and dosage that they find both tolerable and want to take, which means fewer medication changes and less instability. Ultimately, and most importantly, this means fewer days, weeks, and months of distress. Now that we have looked at what PADs are, how to create them, and why someone might want a PAD, let's finish by going over how we can advocate for PADs. Advocacy is utilizing one's power or authority to help empower another by facilitating the expression and implementation of their wishes. As providers, you are frequently asked to act as an advocate for your clients as well as serving as their provider. There's no better way to do this than through a PAD. There are currently 3 major areas that need improvement: provider education, patient education and support, and implementation. Provider education needs to be improved. One study in North Carolina found that only 37% of psychiatrists correctly answered a question regarding their state's PAD statute, and 50% of providers thought PADs would negatively impact patients, presumably due to the misconception that patients will use PADs to circumvent all treatments. However, a Srebnick study found that this isn't the case at all. Of the surveyed PADs, 81% included suggested medications, 64% included medications a patient wished to refuse, and no PADs declined all psychotropic treatments. Importantly as well, PADs cannot prevent the administration of emergency medications. Instead, PADs decrease perceived coercion, which is associated with reduced treatment satisfaction, harm to the therapeutic alliance, a reduction in future help seeking, and an increase in future involuntary treatments. So, what's the solution? By having conversations about PADs between providers and to your patients, you can increase awareness about what PADs are and how they can be helpful. Studies have shown that there is a huge disparity between the number of people who want and the number of people who successfully complete a PAD. One study across 5 cities found that between 4 and 13% of participants had completed a PAD, depending on the city, but between 66 and 77% of participants wanted one once they learned about the option. 2 other studies had similar findings that between 50% and 75% of individuals wanted a PAD, especially if they were offered help to complete one. The primary issue we're seeing is that en masse, patients are unaware that PADs exist and what they are. Secondary, many people who would benefit from a PAD have cognitive and motivational side effects, which makes figuring out and completing a PAD a very difficult task. So in addition to having conversations with your clients about the option, you can use supported decision-making to support people in completing one. This can look like using a session to sit down and go over what it looks like to overcome executive functioning difficulties. We host PAD clinics for Georgia residents, and for those living outside Georgia, your state's protection and advocacy agency, usually named Disability Rights State Name or State Name Advocacy Organization, should be able to offer support. The last major issue is that only 20% of PADs are being accessed by providers when they should be. Currently, individuals are largely responsible for providing a copy of their PAD to their crisis intervention team or having someone designated to fulfill this responsibility. But as we've learned, if someone is truly unable to consent, they aren't going to be able to advocate for themselves, and many people don't have someone in their life to fill this role. So what can be done? You can contact your state legislators to suggest a state registry, place information about PADs in discharge paperwork, and have a standard practice of asking if somebody has a PAD. Here is an overview of PAD statutes across the nation. States in dark green have a PAD statute. States in light green have their PAD as a subsection of their Health Advance Directive, and states in gray only allow you to designate a proxy or POA for all healthcare decisions. If you only take one thing away from this class, please know that outpatient provider support is the greatest determining factor for if an individual gets a PAD. So it's crucial to talk to your patients about PADs. In many cases, supported decision-making can be crucial, but the decisions made need to be those of the individual themselves. This is just a little infographic explaining supported decision-making further. If you're interested, there are many great courses and classes on how to use this approach to protect dignity and autonomy while providing assistance to clients and loved ones. This is a flyer that you can find in the file section of the course or linked in the video description that you can post in your waiting rooms to give your clients more information about psychiatric advance directives. The last thing I want to leave you with is a word of caution about some other PAD resources. The National Resource Center for Psychiatric Advance Directives used to be a really great resource for finding your state's PAD statute. Unfortunately, it's out of date. So you can find a link to each state's PAD or the closest thing to a PAD in the video description below or in the file section of the Canvas course. SAMHSA also made an app called My Mental Health Crisis Plan that is currently disabled, although some people are working on getting it back up and running. One of the unfortunate things about the versions of this app so far is that in many cases it tricks people into thinking they have made a legal PAD when they have not. It can only act as a preference list and isn't legally binding. Here are a list of references used for this presentation. If you have any questions from the course, you can visit our website at padsimprovedcare.org for more information, or email us at info@padsimprovedcare.org. For any course content related questions, you can also post them to the discussion board on our Canvas page.